Thank you all for coming. And thank you, Anne, for the very kind introduction on behalf of Dr. Donahue and myself. And you could tell the difference in the surgeon is wearing the lab coat. The medical oncologist is more casual. We don't see the operating room. But really on behalf of both of us, thank you for having us. And it's our opportunity every year, every 2 years, to update everybody as to what's going on with pancreatic cancer, what we can do, some of the improvements that we've made over the last few years, some of the challenges we still have to go, and some of the recent direction, both in the field at large and at UCLA, that have been made here in trying to treat this disease. And we thank Anne and the Simsman Center for inviting us, and they do wonderful work, which is undervalued, undersupported by and is really dependent on philanthropy to help fund the important work. And any of you that have been to all of our centers know the ubiquitous presence of the Simsman clinicians that offer their support whenever it's needed without questions. So we're going to start by going over pancreatic cancer 2016, and both Dr. Donahue and myself will share the microphone, go over the aspects of related to each of our specialties. And this is sort of an outline of what we're going to talk about. Some of the statistics of the disease, the diagnosis and risk factors, staging systems, treatment options, both surgical and medical, and then again, trying to go into a new venture that Dr. Donahue spearheaded here at UCLA in the last year, which is the notion of a pancreatic integrated practice unit. So we all know that the pancreas is a unusual organ in that many different cell types originate from that organ, and each one of those cell types can theoretically spawn a different type of cancer. And when we speak of pancreatic cancer, we usually refer to ductal adenocarcinoma, which makes up about 90% of pancreatic cancer, and which is the one that is commonly referred to when people say you have a diagnosis of pancreatic cancer. There is additionally a rarer subgroup of pancreatic cancer known as pancreatic neuroendocrine tumors, which are derived from an entirely different cell type, which are called neuroendocrine cells, that manifests completely differently in how it presents clinically, in how patients respond to treatments, what treatments are offered. It's a totally different disease, and in many ways will not be the subject of our discussion, and we, in fact, have a new center sort of dedicated to neuroendocrine tumors, which are only about 10% roughly of pancreatic cancer. We're really not going to speak about that one too much. We're going to talk about the classical pancreatic cancer, pancreatic ductal adenocarcinoma. So here you can see there's different cell types that are part of the normal pancreas histology and that make up the different cells within the pancreas, and each one of them can, in theory, like any parts of our body, be the origin cell type for progression into malignancy or neoplasia, which are synonyms for what we call cancer. And the most common on the bottom, which ups 85 to 90%, is ductal epithelial pancreatic cancer. It is often comes from conditions that are pre-malignant, which are abnormalities in those cells that are benign in nature, which means that they do not have the classical features of cancer, but which over time, if changes occur, and we'll talk about this tonight, genetic changes in the tissue, can gradually move into cancer. And these are some of the subtypes, IPMN, PANN, and there's other subtypes. And this is a little bit akin to what happens in the colon if you have a polyp. If you have a benign polyp in the colon, you take it out and you say, well, it's a benign polyp, and that polyp portends a risk to go into cancer. In the same way, there is precursor lesions in the pancreas, which are very difficult to identify, because it's a completely different organ, of course, that can themselves evolve over time into cancer. So the prognosis really matters, and the treatment type matters, and the prognosis of classical adenocarcinoma of the pancreas is of course much more difficult than those with neuroendocrine tumors. And needless to say, we're not going to get into a whole lot of statistics tonight, but this is the one which is the most common one, which is the one that you could see here, how it appears under the microscope. This is a classical appearance of the cell type of the ductal cells that line the pancreas organ and that morphologically appear here. And even though these cell types there's other cell types that are rare, these are the predominant ones that we speak of. So here, as I mentioned earlier, this is from some scientific studies. These are done on mice and rats. And what they've been able to demonstrate is that gradually, as the architecture changes and as the ductal cells within the pancreas change in morphology, it goes through a series of genetic changes. And the genes, some of these genes are listed here, that evolve and mutate and really become the principal impetus, so to speak, for changing the underlying morphology. And what happens gradually is that as PANIN, which stands for pancreatic intestinal neoplasia, gradually changes over time, it eventually evolves into what we define as cancer, which is a complete breakdown of this structured architecture that should exist in these cells. And over here you could see some of the genes that have been linked to this process. And these genes are things that occur within those cells individually that gradually turn what should be normal, well-defined cells into uncontrolled growth. So this is some of the statistics from this disease. And you can see here, compared to some of the other cancers that are out there, pancreatic cancer is the fourth most common cause of cancer of cancer deaths in the United States in both men and women. The risk is basically equal amongst men and women. This is still quite a bit further down relative to lung cancer and some of the other ones, of course. But what we have seen is an increase both in the number of diagnoses that are made annually in the United States of pancreatic cancer and also in the number of people that pass away from pancreatic cancer. So as these statistics are evolving, we're starting to see this pancreas cancer become more of a common cause of morbidity and mortality, unfortunately. So we really need to, a lot more focus, a lot more research has been done and continues to be done over the last few years. And as you can see here, projected cancer deaths as improvements have improved in some of these other cancers, in particular breast cancer, where drug development is much more robust, and colorectal cancer, which has a better molecular understanding of the disease. In pancreatic cancer, there is still a fundamentally poor scientific understanding of how the disease evolves, and treatment is very difficult to develop. New drug treatments in pancreatic cancer is notoriously been a difficult area for drugs and new discoveries to be developed, and we'll talk about that a little bit as time goes on. So I'm going to go briefly now, before Tim takes over, into the diagnosis and risk factors. So the way we make a diagnosis of pancreatic cancer ultimately is with tissue. We need a biopsy to show that it's cancer before we tell people you have a diagnosis of pancreatic cancer. And these are some of the techniques that we use before a biopsy to lead to the diagnosis, whether they're CT scannings, endoscopic ultrasound, which is similar to an endoscopy, but in which the ultrasound probe can directly visualize the pancreas, MRIs or more sophisticated MRIs of the hepatobiliary system, MRCP, a PET scan, which is often used in other cancers like lymphoma and colon cancer, and sporadically in pancreatic cancer, and most importantly down here, the ultimate way in which we both make a definitive diagnosis, which is a fine needle aspirate, which is taking a piece of the pancreas tissue or associated tissues, either percutaneously, which means through the wall of the abdomen, or with an endoscopy, or if needed, laparoscopically with surgery. Tumor markers such as CA19-9, which is the most common one, are really not the main way in which we make a diagnosis, but rather more of a way to follow patients who have pancreatic cancer and try to guide treatment decisions based on some of the tumor markers. So, here's some images, and we're going to show you a few CAT scans tonight of how difficult it can be to determining whether or not someone really has something abnormal in the pancreas. As we all know, one of the fundamental problems with the pancreas is its location. It's in a very difficult location, deep in the middle of the abdomen, and a lot of veins running through it, arteries running through it, nerves running through it, and it's very difficult sometimes to determine what is normal from abnormal. And we spend about 3 to 4 hours every week in our multidisciplinary conference studying images and trying to determine if that is normal or abnormal, and it requires a degree of expertise that some large centers have, trying to figure out what is something that is more likely to be abnormal versus something that is simply a variation of normal. And before you put patients through procedures and treatment, certainly you have to be pretty confident that that is what we think it is. And here you could see sometimes the imaging is even subtle. So if you have the same patient who's taken on a CAT scan and 2 different breaths based on whether they get injected with a contrast at a certain time, you could either see what you think you're seeing or you could see something else entirely. And here with arterial phase, which is a different phase of looking at the CAT scan, the way the images are collected, you see a totally different picture, which is, and it's subtle here, of course, but a hypodensity here, which is not present here. So just a tiny little distinction can be quite different, so the timing is critical of how you make a diagnosis. We also really consider it important when you're looking at the pancreas to also pay attention to the other lesions and the other organs, in the abdomen. Pancreatic cancers, while not exclusively, the most common area it spreads to first is the liver. Because of the blood supply of the pancreas, because of the lymph node presence between the pancreas and the liver is the most common organ that is affected from pancreatic cancer as a second organ. And so we do detailed images, which are also sometimes quite subtle, to see if there's any abnormalities in the liver. And sometimes, even if we already have a diagnosis of pancreatic cancer, we can then diagnose the liver lesions as being related to that, which is often requiring a second biopsy if needed. But the subtlety here is sometimes very hard to find, and I'm not a radiologist, and so I completely rely on the expertise of our expert radiologists here. One of the things Dr. Donahue is going to talk about is a little bit about the location of the pancreas. When is it resectable? When should it be taken out? What are some mechanisms we can do to make it resectable? What defines whether it's resectable or not? I'm going to let Dr. Donahue get into all of that. Needless to say, there's very subtle veins that are right adjacent to the pancreas. This is the superior mesenteric vein, and this is the superior mesenteric artery. And those vessels are running right through that organ. And we try to determine in advance of any major surgical treatments, or in advance of any treatment for that matter, whether those veins or arteries are involved. And that's also a very complicated thing that, that really, that's what we try to do in a multidisciplinary team. So, risk factors. So we'll go over some of the risk factors. And there really aren't too many well-known risk factors. This is not a cancer like breast cancer or lung cancer where there's clear identifiable risk factors. Smoking is a risk factor for pancreatic cancer as well, just like it is for lung cancer. We've known that for some time. These are some of the hereditary risk factors, though, which are unusual and very uncommon genes. If we see patients who have a family history of breast or ovarian cancer, and they now have pancreatic cancer, we think about BRCA, because BRCA, which is BRCA1 and 2, which are more common in Ashkenaz Jews and other ethnic groups, is now very clearly linked in men and women to pancreatic cancer. So the way we find them is often by saying, oh, I had a family member, sister or mother who had breast cancer and a sister who had ovarian cancer, and then we launch into a workup which involves more sophisticated genetic tests to see if they have a BRCA mutation. And the reason that's important is twofold. One, if they have a BRCA mutation, it sometimes leads to different treatment strategies for that individual patient. And two, it also allows us to screen additional families and find if there are other family members that are carriers themselves of BRCA and whether they should be screened for, in addition to the ovarian and breast cancers, the pancreatic cancer as well. There are other genetic syndromes that are rare listed down here, including ones that are linked like APC to colon cancer and P53 to Li-Famreni syndrome. And these are extremely rare that we almost never know about unless there is a very, very strong family history of that individual patient. The large majority of pancreatic cancer is what's called idiopathic, which means we don't really know how it came about. There's no identifiable genetic predisposition from parent to child that we can identify. There's other risk factors, which include a long-standing history of chronic pancreatitis, diabetes, and changes in glucose metabolism is a very controversial thing. It's not a classical risk factor, but there is a lot of circumstantial evidence that changes in the pancreas and changes in glucose metabolism over time can lead to pancreatic cancer. The environmental factors are listed here: tobacco use, alcohol on some level, obesity, and a high-fat diet have been, in retrospective studies, primarily linked to a risk for pancreatic cancer. So I'm now going to hand the microphone over to the surgeon, who's Dr. Donahue, who's going to go over some of the staging, treatment, surgical, and we'll hand it back and forth a little bit.
Great, thank you, Zev. Dr. Weinberg, sorry. Move on next to staging systems for pancreas cancer. This illustration here shows the pancreas, which is that yellow organ that runs transversely across the abdomen, your upper abdomen, and what we call the retroperitoneum, essentially behind all the other structures. It's directly behind the stomach, and you can see it's intimately associated with the first part of the intestine there. You can see the liver, the gallbladder, and all of the adjacent organs. The pancreas here is highlighted in yellow. Next to the pancreas, there are these essential blood vessels. There's one in blue and one in red. The blue one is the superior mesenteric vein, which is essentially the only vein that drains the intestine. The red one is the superior mesenteric artery, which is the only artery which supplies the intestine. Loss of this artery is essentially incompatible with life. So when it comes to surgical procedures and whatnot, the artery is off limits. So even resecting the artery and putting it back together leads to major morbidity. So if the tumor involves that superior mesenteric artery, surgery is usually not an option for patients. The vein is a different story that we'll talk about. This is an example of a cancer, the yellow thing there, that's in the tail of the pancreas. This would be considered a resectable lesion because it is limited to the pancreas and doesn't involve any other adjacent structures. This here is a cancer within the head of the pancreas. Again, it's limited to the head of the pancreas, and it would be considered a localized cancer in the head of the pancreas, which is resectable. Like the one I just showed you in the tail, the treatment for these patients would likely, in most places, in most cases, be surgery up front, and then most often, if not invariably, chemotherapy after the operation. So again, another resectable lesion. This, you can see here, the tumor is in the neck of the pancreas. It's approximating or coming close to that red structure, which is the hepatic artery. Because it involves the hepatic artery, it would be impossible or not possible to resect the tumor to negative margins without also resecting that blood vessel. So when in cases like this, where it involves an artery or a blood vessel in the area of the pancreas or a named artery and blood vessel, it's considered at least initially unresectable. The only way that surgery really helps in this disease is if you're able to remove it and have all those margins be negative. In order to remove this tumor and have the margins be negative, it would require a segmental resection of that artery. In cases like this, which I'll talk about, what we usually do is treat with chemotherapy and or radiation therapy first to try and shrink that tumor down and allow for what is a possible margin negative resection without having to manipulate that artery. Again, here's another problem. You can see all these blood vessels that are intimately associated with the pancreas. There's a tumor here now in the uncinate process, which is the bottom of the pancreas there, very close to the superior mesenteric artery and vein. Same concept, it involves the blood vessel. This would be considered, for the most part, an unresectable tumor at the outset, and this patient would be given chemotherapy and or radiation therapy first rather than surgery. Location, distribution of cancers in the pancreas. Most cancers occur in the head of the pancreas. You can see it says 60 to 70%, or about 3/4 of tumors occur in the head of the pancreas, about 5 to 10% in the neck and body, and about 10 to 15% in the tail of the pancreas. A little bit of a mystery as to why most of them occur in the head. It's the most voluminous part of the pancreas, so that's where most of the pancreatic parenchyma is. My other suspicion is that the bile duct from the liver passes through the head of the pancreas. It's close to the intestine, so I think there's probably a lot of inflammation in that area, which is an accelerator of cancer development. So a good 2/3 of tumors occur in the head of the pancreas and a minority in the tail of the pancreas. This is the American Joint Commission on Cancer staging system for pancreas cancer. You can see it's really complex. We're in the process of revising it to make it even more complex. In practicality, we don't really use it that much, and we don't use it at the time of diagnosis or the outset because it's dependent on whether or not lymph nodes are involved, and that's impossible to tell without looking at them underneath the microscope, and or how big the tumor measures and whether or not it extends outside of the pancreas. But the key points that I want you to see in this AJCC, American Joint Commission on Cancer, TNM staging system, is that you either have N1 or N0 disease. So if you have one lymph node positive, it's considered N1 disease, whereas many other cancers have a range of Ns, right? So if you have 0 to 5, you're N1, or 5 to 10, N2. For pancreas, it's thought that once you have a lymph node involved, there's enough prognostic information such that it's just N1 versus N0. That's the main point here. I think in the next version of the staging system, they're going to include a gradation of Ns. But most patients have either stage 2 or stage 3 or stage 4 disease. There are very few patients who at the time of diagnosis have a stage 1 disease. But again, we don't really know all this information, so we don't really adhere to it too much. This is a much more practical and adhered to staging system for the time of diagnosis, and it's separated into potentially resectable, borderline resectable, locally advanced, and metastatic. And this is how we kind of categorize patients in terms of how we determine what their treatment is. So the metastatic is when the tumor has spread to distant organs. That's pretty self-explanatory. Usually often goes to the liver. Dr. Weinberg showed you a picture or a CT scan of the liver. It can also skip the liver and go to the lungs. It can also go to anywhere essentially in the peritoneum or anywhere in the body for that matter, but most commonly goes to the liver. Potentially resectable are those lesions that are isolated to the pancreas that don't involve the surrounding blood vessels and look like that they can be resected to having those margins negative without manipulating those essential blood vessels in the area. The two in the middle are borderline resectable and locally advanced. It's a large proportion of patients, probably almost up to a third of patients have one of these two middle stages. And borderline resectable is essentially locally advanced light disease. It's when the tumor has grown just locally to involve those blood vessels such that they can't be removed. And again, this borderline resectable is when there's not extensive involvement of the blood vessels in the area, but a little bit less so. And it's just important to understand this definition because most places, and us more and more so, are starting to see it a little bit differently, or patients with it a little bit differently than those with locally advanced disease. But just think as a general category, patients are those folks who have potentially resectable disease, undergo surgery first, for the most part, and then adjuvant therapy, chemotherapy after the operation, which Dr. Weinberg will talk about. The metastatic at the bottom, the other end of the spectrum, folks who have disease that spread to the liver, the lungs, or elsewhere, For the most part, surgery is not involved in their treatment algorithm or sequence, and they're definitively treated with chemotherapy and/or radiation therapy. Borderline resectable or locally advanced, that middle group, that's about a third of patients, have upfront chemotherapy and/or radiation therapy, followed by surgery, and then maybe even followed by additional chemotherapy. But I'll focus on that group a little bit more towards the end when I talk about some of the new work we're doing in the integrated practice unit at UCLA. So again, I told you the treatments here, that potentially resectable surgery. The two surgeries that are most commonly done are if the tumors in the body and tail of the pancreas, a distal pancreatectomy. If the tumors in the head or neck of the pancreas, a Whipple resection, or a pancreatic duodenectomy. This is, you can see again the localized cancer in the tail of the pancreas. And the operation would be just to cut the pancreas just to the right of where that tumor is, send it to the pathologist, make sure those margins are all negative at the time of surgery, but remove this whole region that's shaded in green, which includes the spleen too. And that's because the lymph node basin from this area where it drains is usually in the splenic hilum, and we want to get all the lymph nodes, and we want to make sure that the margins are negative, and we don't sacrifice the cancer surgery for saving the spleen, which is of questionable benefit. So this is what it kind of looks like after everything is removed. The Whipple resection is a bit more of an extensive operation than the distal pancreatectomy, but you can see on the right there, the tumor is the gray thing, and the dotted lines are everything that's taken out. It's the whole region. It's the first part of the intestine, the head of the pancreas, the bile duct, all come out as one thing. And then we got to hook everything back together again, which is shown on the right, where we sew the pancreas, bile duct to the intestine, and then again, either the duodenum or the stomach back to the intestine again. It takes about 4 to 6 hours or so to do, but there are different ways to do it. For the most part, we leave the entire stomach intact here at UCLA because that operation was first described at UCLA. So we were true to our founders. The Whipple operation today, very safely done. It's safely done at centers where there are high volume of operations done. Mortality rate significantly less than 1% at places where a lot are done. This increases to much higher in folks who just do a few of them, which I'll show you in a little bit. Complications are well managed. Very rarely, very rarely do we need to reoperate on patients. When things do and happen, they can oftentimes be managed with interventional radiology. Quality of life after surgery is really good. There are a few long-term sequelae of having Whipple resection. 5-year survival rates, most reported series are between 25 to 30%. And then the last statement here is cure is not possible without surgical resection. But it only does help if you can get that tumor out and have those margins be both grossly and microscopically negative. So back to Dr. Wainberg for some chemotherapy and medical treatment for pancreas cancer, and then I'll finish off by telling you what we're doing at UCLA.
Thank you. So at some point in time, almost every patient with pancreas cancer gets chemotherapy. And the reason for that is that, as Dr. Donahue just said, even if it's a small stage 1 tumor that is usually found accidentally, so we usually don't find stage 1 pancreatic cancer unless it's incidental finding, which means the patient had a CAT scan for an unrelated reason, and we see a very small subtle area in the pancreas, and then we take it out, and then we find a stage 1 cancer. Even those folks, there's a good indication to give chemotherapy because unfortunately, chemotherapy is all, so far, the only thing that's been shown to reduce the risk that cancer will come back. And, we are trying to improve on that with all sorts of new ventures, which we'll talk about in a minute. But at this point in time, in 2016, what we're able to say is that after surgery, chemotherapy is the only thing that's been medically proven to reduce that risk of recurrence. Because pancreatic cancer is a mystical disease. It could have cancer cells that sneak out of the area, sneak out of the lymph nodes into the bloodstream, and then could decide to pop back up 3 months, 6 months later, a year later. And we don't understand why. We just know that if you can kill them off at the microscopic area, ideally before they spread, that is a better chance at inducing at reducing the chance that they'll ever grow into those organs. So as Dr. Donnie said, only 15 to 20% of patients are truly resectable, and only 25 to 30% of node negative and 10% of node positive patients are alive at 5 years. So we have a lot of improvement to do, and most of the research has evolved around chemotherapy, which are obviously just drugs that kill cancer cells preferentially, and sometimes chemoradiation. So this concept called adjuvant therapy. Adjuvant means after surgery, what you're going to do after surgery to reduce that risk of recurrence. And there's been a whole host of trials that have been done over the years, including one recent one which established one of the new standard treatments, which is called two drugs, gemcitabine, which is IV, capecitabine, which is oral. This was just presented about 2 months ago at our annual meeting, ASCO meeting, which was about a 800-patient study done out of Great Britain that showed that the two drugs are better than one. So that's how clinical research evolves. Clinical trials are done all over the world all the time in pancreatic cancer, and improvements are hopefully, while modest, continue to be made. So here you'll see some of the standard drugs, some of the treatment options. And these are the treatment options mainly for patients with metastatic pancreatic cancer, but really the drugs are essentially the same. The same group of drugs we use in stage 2 or stage 3, or what Dr. Donnie referred to as locally advanced pancreatic cancer. The same regimens are essentially used in stage 4 pancreatic cancer. The drugs and the regimens are essentially the same. They're just being tested in different venues. So gemcitabine is one of the main drugs. There's a big regimen called FOLFIRINOX, and a newer regimen called nab-paclitaxel, whose trade name is Abraxane, plus gemcitabine. And these are the two main treatment regimens that nowadays in 2016 people use, FOLFIRINOX and Gemzar and nab-paclitaxel. The other ones have become less popular due to ineffectiveness, or less effectiveness, I should say, or side effects. Now, ultimately, when you decide what treatment a patient should get, it's a pros and cons discussion with each individual patient about what you're trying to achieve out of the therapy and what are the side effects. Because any and all of these drugs, whether it's FOLFIRINOX here or nab-paclitaxel plus gemcitabine, cause these side effects. And whether it's fatigue, which is ubiquitous in all chemotherapy regimens, diarrhea, which is spelled the British way, I think, peripheral neuropathy, which is a much more common finding in certain drugs, or bone marrow issues like neutropenia or thrombocytopenia. These portend different risks to each patient depending on what the individual characteristics of that patient are and what degree of bone marrow suppression is acceptable and what isn't. So this is usually made on an individual case-by-case basis, but these are the two main regimens we use. So some of the challenges that we have, just from a 10,000-foot view in this disease, as Dr. Donahue earlier alluded to, is there isn't really a true consensus as to what's locally advanced or resectable, meaning there is a lot of subjectivity in this field, because as you can see, making a diagnosis of pancreatic cancer isn't as simple as it might seem. And once that diagnosis is made, determining the accurate stage isn't as simple as it might seem. And what to one person is surgically resectable at UCLA may not be surgically resectable in another hospital. So there is a degree of subjectivity in this disease, which is in many ways fairly unique to pancreatic cancer because of the complexity of both the establishing the initial diagnosis and making the staging system. So this field has struggled over the years with consensus. And there is no consensus in many ways as to what's truly locally advanced or resectable disease. There's difficulties with primary tumor anatomy. Elevated CA19-9, which is a tumor marker at baseline, has been found to be, in many ways, a poorer prognosis. And whether or not you definitively have metastatic disease isn't always easy to prove. And one of the fundamental problems with pancreatic cancer is that the majority of treatments are empiric, which means we don't have an isolated gene that we can identify and target in pancreatic cancer, the way, for example, breast cancer has estrogen receptor. In 80 or 70% of women with breast cancer, they have estrogen receptor positive disease. Well, that's a target. You can go after that with a drug and block the estrogen receptor, which will lead to reductions in the size of these tumors. Pancreatic cancer has no comparable gene to that we can identify, that we just don't know. There are lots of genes that are abnormally mutated and active in pancreatic cancer, but they're what's referred to as non-targetable. They're not druggable genes. We can't go and say 80% of pancreatic cancer patients, for example, have a mutated gene called KRAS, but there is no way that we are aware of to block that KRAS gene. And that's one of the challenges in this disease. And the other thing is, over the last few years, immunotherapy has been a source of great excitement in the field of oncology. And I'll talk about this in a few minutes, but the principle here is that we, with medicines, with drugs or vaccines, manipulate the immune system to attack the cancer. And in pancreatic cancer so far, immunotherapy can only be considered experimental, meaning it hasn't been proven the way it has in melanoma and more recently in lung and bladder cancers. So some of the approaches that different groups are taking, including our own, to try to treat pancreatic cancer involve a treatment of either different genes or different ways of getting into the tumor. And one of the challenges with pancreatic cancer is that the drug delivery is not very good. So when you have the pancreas, which is deep in the middle of the abdomen, the drugs have a tough time getting in there. And we've seen that in patients after biopsies and after resections, is that we're not sure that all the drugs that we were giving are getting into the right organs. So that's called the tumor stroma, and we'll talk about that. These are other ones. Notch, PARP inhibitors are now being used very commonly in patients with BRCA, which we talked about earlier, BRCA-associated pancreatic cancer. KRAS is the most dominant oncogene in cancer, and in particular in pancreatic cancer, but we don't have a good way to block it. And now immunotherapy and vaccine-based approaches. So the stroma, the stroma is the area adjacent in the pancreas that prevents, that is part of the desmoplastic area. So it's up to 90% stroma. And these are cells that look like normal pancreas, but are mainly there to defend the pancreas against the outside surrounding immune system. So in some ways, the pancreas is a unique organ in that it has a very high stromal component, which are muscle cells and nerve cells that sort of surround this organ. And that's good in some ways, but one of the ways in which it's challenging is that if you have a strong stromal component, you need to break down that stromal component to have drugs get into that organ. And in pancreas cancer, compared to any other cancer, has a very high stromal component. So it really probably prevents anti-cancer agents from getting in there. There are drugs that are now being developed. A number of these are developed at UCLA and other institutions to break down that tumor stromal barrier. So to try to give medicines that break down the stroma, break down those stromal cells that surround the pancreas, and allow for better drug delivery. So in some ways, if you get better drug delivery into the cell, and one of the ones that's promising now is this final one, PEG hyaluronidase, you can introduce a greater number of drug directly into the cancers. And this is also often referred to as the tumor microenvironment, which is a rich microenvironment within the tumor, which is fed by immune cells, fed by nerve cells, but which is really blocking the cancer cell from getting, from the drugs getting absorbed. And this is a pretty unique phenomenon in pancreatic cancer, and in my opinion is one of the main reasons why drug development has been so stalled in this disease, is because we are not sure that any of our drugs, or to a large extent, are getting into where they need to get. And so a huge effort of research in this country right now is focused exactly on this area, breaking down the stroma in this disease. So there's a PARP inhibitor. This is just one example. We've done a lot of research in this field at UCLA, and PARP inhibitors break down DNA, and this is particularly relevant for patients with BRCA. So they're already approved for BRCA-associated ovarian cancer. They're going to be approved for BRCA-associated breast cancer, and for pancreatic cancer, they're used. So if you have a patient who's got a BRCA-associated pancreatic cancer, which is very rare, up to about only 1% of pancreatic cancer, to my knowledge, you would try to find a way to introduce this drug into your armamentarium of drugs. These are very complicated signal transduction pathways, which are very common in pancreatic cancer, which go on in each cell. Each pancreatic cancer cell has this pathway, and different drugs are being developed to block different parts of this pathway. You can see here this mutation is referred to as KRAS here, which is, as I mentioned, the dominant oncogene in cancer. The biggest problem we have is that we can't block this gene directly. So science has not figured out a way to block this gene and silence it. And if we did, we all think we'd be onto something pretty exciting. We know how to block genes above it and block genes below it, and some of those are approved and used very routinely in lots of cancers. But KRAS, which is the dominant oncogene, 90% of pancreatic cancer, is what's called a non-druggable target. So immunotherapy and vaccines therapy, and this is one that we've been involved with here at UCLA, which are ways of stimulating the immune system. So you try to take what is a person's normal immune system, their T cells, their cells that should be fighting infections and fighting the development of any abnormal presences, fundamentally have a difficult time recognizing a lot of cancers. So melanoma was the first area that it became clear that the immune system, you can trick the immune system into attacking cancer, either by manipulating it through what's called checkpoint inhibitors, which are drugs, and you might have seen them on TV because they're marketed directly to consumers. Drugs like Opdivo, which are checkpoint inhibitors, like PD-1 inhibitors, or other vaccines, which basically fundamentally are trying to take what is an inactive immune system and trick it into attacking the cancer as foreign, trying to teach it and to attack cancer and get the T cells into the cancer and see if it can do what it should have done and kill off some of those cancer cells. So we don't know how to do that on our own. So we use drugs to manipulate the immune system, either vaccines, this is one such vaccine that we did at UCLA, or these checkpoint inhibitors, which unleash the T cells throughout the body to attack the cancers. So we did a vaccine trial at immunotherapy and at UCLA, and we've been doing this for a few years. And it was very difficult because we have to give patients immune therapy, which sounds nice in theory, but in practice is not that simple. It's associated with a whole different group of side effects. So it doesn't have the chemo side effects that we all know and love, the fatigue, the nausea, the vomiting, the other stuff, but it has these very compelling and challenging immune side effects, which can be infusion reactions, huge abnormal reactions of the immune system that cause autoimmune diseases. So we're dealing with a whole different side effect profile sometimes, which can be sometimes very challenging. And this was one trial that we did at UCLA, and fundamentally, one of the challenges that we had is the same challenge we had with chemotherapy, is that we're still not sure if the immune cells are getting into the cancer, and it's very difficult to know that because there's no good way to test that in the blood. You can't take someone's blood test and be sure that the immune system cells are getting into the cancer, and you can't do repeated biopsies on patients. It's very challenging to do that. So fundamentally, we're stuck in some ways with the same dilemma that we have with the stroma, which is how do we know those immune cells are getting in there? We rely on our tools like blood tests, CAT scans to try to give us an idea if that's happening, but there is a bit of guesswork involved. And one of the challenges with immune therapy has been that the immune system may not fundamentally recognize pancreatic cancer as foreign, and those immune cells may not be getting into the cancer. So this is still a big black box, in my opinion. While it's clear that immunotherapy is now very important in melanoma and very important in lung cancer and bladder cancer, those cancers, we have proof, we have evidence that those immune cells were getting into those tumors because we biopsied them after treatment, and enough patients had shrinkage of their tumors to prove that it was working. In pancreatic cancer, it's not the case, unfortunately. We're still, I'd say, in our early developmental strategies for immunotherapy in pancreatic cancer, and hopefully we will find a way to get the immune cells into the tumors. But to be fair, because we always face these questions, we still regard this as a very experimental approach. So some of the trials, and we do a lot of trials at UCLA. It's a lot of what we do, a lot of what I do, and Dr. Donahue as well, is we try to develop drugs, new drug development, and some of them are listed over here, whether it's chemotherapy plus PD-1 inhibitors, which are a type of immunotherapy, chemotherapy plus pegylated IL-10, another type of immunotherapy, modified FOLFIRINOX regimens, trying to make them more tolerable, another trial with an immunotherapy component that we're not open yet, that we're hoping to open, and other vaccine-based approaches. Immunotherapy is probably the subject of about 50 to 60% of our clinical trials at UCLA. That's a product of the times we live in, of the fact that the drug development field has moved in a lot of ways from nobody's developing new chemotherapies anymore, or new, in some ways, targeted therapies even. We've evolved trying to figure out what the best immunotherapy approach is for every cancer. And in some ways, we figured it out for a bunch of them, and now there's still some improvement to be made in pancreatic cancer, to be sure. So I'm going to hand it back to Dr. Donahue, who's going to finish us off with some of the center that we have here at UCLA and some of the work we're doing here.
All right, so about 2 years ago, we started the process of transitioning how we, as multiple different types of specialties, deliver patients pancreas cancer care at UCLA. And it's still a process in evolution. I have no degree in evolution, but I understand that this is a process in evolution. But it's called the Integrated Practice Unit, but we're off to a good start. What this shows to you is that pancreas care, pancreas surgical care, is best done in hospitals where there's a lot of it done. And so, there's been a large push and force for regionalization of pancreas care, pancreas cancer care. This is one example where you can see on the right is pancreas highlighted, or pancreatic resection, and the more you do as you go to the right, the lower the adjusted mortality rate is. So clearly a strong correlation between volume and outcome. This is on a hospital basis. More so than any other surgeries, colectomy, gastrectomy, stomach is removed. Esophagectomy, where the esophagus was removed, also shows a strong trend like this. But large push for regionalization of care and surgical care. This is now on per surgeon, where you can see the more that you do, the mortality rate goes markedly down. And at UCLA, we do over 150 pancreas resections per year, and it's divided between 2 to 3 of us. So we are all considered high-volume pancreatic surgeons. This is an old picture that needs to be revised. The website is in submission for revision, but it just shows you that there's a lot of folks who are focused on pancreas cancer and from different specialties. What is an integrated practice unit? Well, an integrated practice unit was first described in the Harvard Business Review about 2 years ago. I was at a conference, a surgical conference, and there was a session on how to fix healthcare because it's so broken. This article was referenced, and I read it with great interest afterwards, and it has since changed how patients with pancreas cancer are treated here. But what they describe here is one of the ways to make care more affordable and efficient for patients is to organize into these things what are called integrated practice units. And an integrated practice unit, it's defined as a dedicated team of clinical and non-clinical personnel organized around specific diseases to provide efficient and comprehensive care. I underline efficient because that's extremely important. Each member of the IPU meets frequently to review outcomes on their own performance, and they must see themselves as a cohesive unit, which we all do here. The co-locating staff and doctors in the same must be in the same multidisciplinary clinic, and just that clinic is just one component. It's greater than just seeing patients in the same physical location. So we have refined and developed our multidisciplinary clinic workflow and process, which is outlined here, where you can see that in the days prior to meeting patients, we have their imaging reviewed to make sure it's of sufficient quality for us to be able to make treatment decisions and judgments, and if it's not, we ask that it be done beforehand, before being seen. And then the clinic begins with a conference where all practitioners and other staff who are going to see and take care of patients meet. This includes not only surgeons and medical oncologists and radiologists and gastroenterologists and cytopathologists and surgical pathologists and the folks from the Sims-Mann Center attend. Elizabeth Cleary comes. The genetics counselors come. So it's everyone and anyone who could help and be involved in the care of patients who are being seen right after that conference. So if anyone has any memory loss, it doesn't affect how the patients are treated that right afternoon, and there's no excuses that we forgot about the plan. The specific goals of the clinic are to work together as a team, provide efficient, value-based care. This is important to provide rigorous evaluation of our outcomes by having this organized methodology to expand enrollment in clinical trials that Dr. Wainberg just said, many of which are initiated here at UCLA, and obviously to increase the number of patients who we see and treat, and we're doing just that. One specific example that I wanted to tell you about, I know we're short on time, but is about those patients with borderline resectable or locally advanced disease. They're the ones, the third of patients or so, who don't have tumors isolated to the pancreas that can be taken out or spread elsewhere. The ones that have just grown too large to involve the local vasculature. This is something that I've been spearheading for the last 5+ years or so, are a rigorous, continuous evaluation of how we're approaching these patients, how we're treating them, the order of things we're doing it in, for how long we're doing it, and whatnot. But we've brought this as one of the focus areas into our integrated practice unit. So again, the borderline resectable and locally advanced patients receive radiation therapy or chemotherapy prior to surgery. To remind you, these are the tumors that involve the blood vessels and the structures in that area, and again, cannot be taken out. One in this audience may ask, why not just take out those blood vessels up front? It's a good question, and it's something that was done probably about 15 or 20 years ago, and we found that the folks just don't do so well if you just start off by doing large operations that involve major vascular reconstructions and resections. What we learned through that experience is many of those patients who have blood vessels involved potentially have disease that's located outside of that area. And so even though you don't see it on a CT scan or a PET scan or any other high intensity or high resolution way to diagnose it, it may still be hiding out there. And the vessel resection is more extensive. It leads to longer recovery, and it just delays receiving chemotherapy earlier. I always tell patients that the last thing that I would want to do is to do a major operation that involves a vascular resection and reconstruction and find out that the tumor recurs elsewhere, like in the liver, a few months later. That would have told me and everyone that we treated you wrong and in the wrong sequence, and that surgery may have been of questionable benefit. So this is our experience with patients with borderline resectable or locally advanced disease, those tumors that have grown just a little bit too big. You can see this is the last update. It's now about 100 patients, but we started this change in way these tumors are treated in 1992 and have grown since that time and increased the experience, and we're doing it more frequently. I'd say we're operating on folks who have received chemotherapy or radiation therapy before surgery probably at least 2 a month or so. But despite us doing more and being a little bit more aggressive with this treatment, those folks who we decide at that multidisciplinary integrated practice unit tumor board who would benefit from an operation, most of them, almost all, are still having their tumors removed at the time of surgery. But the one thing that we have not done is change the chemotherapy duration before the surgery. And this is a very unique thing about UCLA in comparison to our peer institutions, which I'll show you. Dr. Weinberg talked about adjuvant therapy after surgery. Even those patients who have surgery up front and get chemotherapy afterwards get 6 months of adjuvant therapy. And so what we've done is take most, if not all of that, and take it from just after the operation and put it before the operation, because we think that that really is beneficial and will identify those folks who really do need an operation and who would benefit from an operation. Just because you can do it doesn't mean you should do it. Vascular operation, we're taking out a lot more veins now. So again, as I said, getting more aggressive. We're taking out portal veins, perimesenteric veins, reconstructing them, and you can see vein resections have gone up as the years have gone by. And doing this, I'd say, probably once every other month at the least. But our survival has not changed, right? Despite the fact that we're getting a little bit more aggressive and operating on more patients who we wouldn't have when we started this experience, we're still selecting what we think are the right ones because the survival is still unchanged, and it's excellent. It approximates 4 years. Just a few more slides here, but I just want to compare what we're doing here to other studies, other institutions, and make a point that we give a much longer course of chemotherapy before that operation. You'd need to get the 6 months after anyways, and I think that that's a major contributor, not the only one, into the fact that we have amongst the best survival that's been reported for this group of patients. There's been a major criticism that, in our results in our national meetings that, well, we're taking a select group of patients to surgery and we're not reporting how many that we're taking. Well, so I started saving all the records since 2002 to respond to and rebut these criticisms. And you can see those patients with borderline resectable disease, about 60% from when they're diagnosed, are going to surgery. So during that 3 to 6 month course of chemotherapy, 60% head to an operation, which is comparable to what everyone else is doing. I think we're just getting more chemotherapy into these folks, and it is effective and what is needed. Locally advanced, so those tumors that are a little bit bigger than those borderline resectable, it's the exact same story here. We're given more chemo before surgery, and the patients who undergo an operation are doing really well. About a quarter, so about 20 to 25% of patients who have those locally advanced tumors from the time of diagnosis make it to a therapeutic resection, where again, as I said at the beginning, you got to get to negative margins or you didn't do much help. Just to compare this to our other patients, so if you look here, Dr. Weinberg had said that the patients with stage 1 disease it's very rare. Most have stage 2, 3, and or even 4 disease. Median survival, this is UCLA statistics of patients with stage 1 disease who undergo an operation, is about 45 or 36 months. And if you look at our borderline resectable or locally advanced who have therapeutic resection, it's 62 and then 40 months. So it's about the same as those with early stage disease. So if you can get treated and we decide that it's appropriate for you to have an operation, you're going to do as well as people who are diagnosed with early stage disease. Now, are we missing people because we're being a little bit more selective or treating for longer? I would argue probably not, because if you see those who progress during therapy who don't have an operation, survival is about 18 or 16 months, which I think can likely be achieved in most cases with disease at this stage with multi-agent chemotherapy. So, as I said, this is part of the IPU. These are some of the questions that we're beginning to publish on from what we're asking in the integrated practice unit. This is a recent paper that we just published about which patients should also receive adjuvant therapy, right? So we ask you to get this chemo before surgery, longer of it, 6 months even. It's difficult to do that and then have a Whipple resection and then recover and get even more chemotherapy after that. But we've done a comprehensive, high detailed analysis on those patients who we think would really benefit from additional chemotherapy after surgery. A flip question is, do I really need to do all 6 months beforehand, or can I do an abbreviated course before and then go to surgery and save some of that up for the adjuvant setting or after surgery? So it's the reverse question, essentially. And we're asking this question in the integrated practice unit now. And what we found essentially is that if your CA19-9 goes down to normal during that preoperative chemotherapy, it's appropriate to do surgery if you get that 19-9 normal, even if it's short of the 6 months. So while the 6 months or more, or almost a full course of chemotherapy is beneficial for everyone, there's a subgroup of patients who, if their tumor marker normalizes, it's appropriate, we found, to take you to surgery at that point. And we can see that here, because if your tumor marker normalizes, the CA19-9 in the yellow, the less than 6 months, your survival is really, really good. If it doesn't, your survival is poor. And it's better for you to get the full 6 months of chemotherapy if your marker doesn't normalize, and you're more on the order of what we have seen in survival for borderline resectable or locally advanced disease. So again, an example of us performing a rigorous evaluation of our outcomes and trying to objectively analyze how it's best to treat patients with all stages of disease. So in conclusion, on behalf of Dr. Wainberg, points to take home, I think, are, pancreas cancer, large burden of disease in the United States. It just went from the number 4 to the number 3 leading cause of cancer-related deaths, and the projections are that it's on the uprise to the number 2 cause. Regionalized care leads to better outcomes, both practitioner level and hospital level. So we feel that it's important that patients be treated in high volume areas. I know for a fact that over 50% of the pancreas surgeries that are done in the state of California are done at hospitals that do less than 5 of them every year, which is a frustrating statistic. But nonetheless, we're still trying to recruit everyone to come here so we can get bigger and even better. Molecularly targeted immunotherapy treatment approaches, Dr. Wainberg described those, particularly immunotherapy treatment, is still really finding its place in the treatment of pancreas cancer, but I strongly do think it will find its place. And we have developed this new integrated practice unit, which incorporates both physicians, other caregivers like Elizabeth Clary from the Sims-Mann Center, to comprehensively take care of patients in the exact same place at the exact same time. So a patient coming to one visit will definitely leave with a comprehensive plan of state-of-the-art care in just one visit. You don't have to see the surgeon and then the gastroenterologist and then the medical oncologist and then whoever else you need to see afterwards. It all happens in one place, in one time, at one visit. So the Harvard Business Review would even think that that was efficient. And we are performing a continuous evaluation of our outcomes, both surgical outcomes, patient care outcomes, and clinical trial outcomes to continue to improve that care. So, this was Time Magazine and Forbes Magazine, I think, last year. But hopefully someday these headlines will be for drugs that are for pancreatic cancer. And Dr. Wainberg and I are working as hard as we can to try and make that be reality. So thanks again for your attention. And on behalf of you, I think we enjoyed this evening and would be happy to take any questions. It depends. So it's. Oh, sorry, I already disobeyed. What is the symptoms of pancreatic cancer? It depends on where the tumor forms. For the most part, pancreas cancers are very asymptomatic until they have developed or grown to be somewhat large and or extensive. It's thought to be one of the quote-unquote silent killers. If the tumor forms in the head of the pancreas, the bile duct goes through there, and so most folks develop jaundice, the painless jaundice from the blockage of the bile duct. In the tail of the pancreas, there aren't many symptoms. It's usually abdominal pain, back pain, weight loss are the most common symptoms. So head cancers are usually diagnosed at an earlier stage than tail cancers because tail cancers tend to be more asymptomatic than head cancers. But jaundice, abdominal pain, back pain, weight loss.
Okay, I'll take that one. So it's the question's really about the quality of life as it relates to getting the chemotherapy in advance of surgery. So the quality of life chemotherapy is a big challenge, obviously, because we all know that chemotherapy is no fun and has a lot of side effects. Fundamentally, when we talk to patients about chemotherapy before surgery, we know that it's going to have quality of life issues. We know that those few months, whether it's 3 or 6 or whatever that patient is going to get in advance of surgery, is going to have side effects. But the statistics that Dr. Donahue showed and the trend in this disease has suggested that those side effects are something that are worth enduring if in the long term the outcomes are better. So for sure, the patients, any and all patients that get whatever chemo regimen they're going to get are going to have a lot of side effects, whether it's related to fatigue, nausea, hair loss, diarrhea, you name it. So the question is, what we try to ask ourselves when we're treating a patient with pancreatic cancer, what's the goal and what are we trying to achieve? And in cases like some of the ones we talked about here at the end, the statistics are pointing to, the studies are pointing to a sense that the long-term outcomes are better because we're, in the long term, reducing more of the cancer burden.
So are other institutions also giving 6 months of chemotherapy? That 6 months is best? It is, and I'm really excited about it, and I am every time that I present it and we reanalyze the data because we keep getting a little bit more aggressive, and I keep waiting to see the changes in things, and it's not. And I'd say that it's institution dependent. There are many institutions that give a prolonged course of chemotherapy beforehand, both on the West Coast, on the East Coast. Our peer institutions like MD Anderson, for the most part, usually gives a little bit shorter. They give 2 or 3 months and they give radiation. Memorial Sloan Kettering gives longer duration of chemotherapy, like up to 6 months. And so they're finding similar results too. I would say it's pretty institution dependent. There's no right way to do this. But we think that because of our exciting survival statistics that we're doing it right. He can answer the treatment part. There are markers that can be used and stained to try and distinguish between pancreas cancer, or duodenal cancer, or colon cancer. There are different cell type origins, right? So pancreas cancer is usually kind of this pancreatic biliary cell type, and there are different, markers that are characteristic of that cell type or origin. Duodenal cancers, colon cancers are usually intestinal type, and there are different markers to be able to distinguish those two. And so I would just encourage. We just looked at this for ampullary cancers because there's pancreatic biliary and intestinal type, and they converge on the same area, and we made this argument that the histopathologic type is better than where they originated from, and it doesn't matter anyways, and whatnot. But I think a comprehensive pathologic analysis, 95+% of the time, is usually able to distinguish between pancreas versus an intestinal, colon cancer, duodenal cancer versus pancreatic cancer. But Dr. Weinberg can speak more to how that impacts the chemotherapeutic regimens.
No, I think that's about it. I mean, you're right, there's a percentage of time in which you can't always distinguish, but it is going down. That number is going down as the pathology has become more sophisticated. You're able to narrow it down. And even if you can't determine definitively always if it's colon or pancreas, which does happen maybe 5% of the time or whatever it is. The drugs themselves are very similar nowadays between this wasn't the case 15 years ago when we didn't use regimens like FOLFIRINOX and things of that nature. But these are actually very similar drugs to what we use now for pancreatic cancer and for colon cancer. So in many ways, that has become less relevant clinically. But it's always nice to know where it started. We all agree, yeah. Do you have a question?
It actually is a good marker of how the treatment's doing. Its most useful place has been shown to be changes during treatment. So CA19-9 is not necessarily a specific or even a sensitive marker for diagnosis of pancreas cancer. Or even a measure of how much disease is there at the beginning, but changes in it during treatment have been, in the literature, been borne out to be the best place for it. There are other factors that we look at. As I said, the only real way that surgery helps is if you can get those margins to be microscopically negative. So if it looks like that is possible, and a tumor marker normalizes, then we have been recommending surgery short of the 6 months now. It is the most prognostic and helpful marker. Looking at univariate, multivariate analyses, CA19-9 really bore itself out extremely well. So best place for CA19-9 is as a measure of response to treatment. As long as you can get negative margins and that CA19-9 normalizes, we found that because of these great survival statistics that it's time to do surgery. It's a difficult, the question is about the relationship of pancreatitis to pancreatic cancer. Pancreatitis, both chronic, for the most part, and acute pancreatitis or intermittent acute pancreatitis are risk factors for developing pancreas cancer. It's thought that you need underlying genetic mutations to accompany the inflammation to develop into a full cancer, right? So Dr. Wainberg talked about like this KRAS mutation. That in and of itself can get you as far as just like the precancerous lesions, these pannins or these colon polyp-like things. But what inflammation can do is work coordinately with the mutations to push for full transformation to pancreatic cancer. Genetic chronic pancreatitis is PRSS1, or there's other SPINK, whatever, related to metabolism of pancreas enzymes, is the strongest risk factor for the development of pancreatic cancer. So genetic hereditary chronic pancreatitis is an extremely high risk factor. But again, you need accompanying genetic mutations with chronic pancreatitis or pancreatic inflammation to develop pancreas cancer.
That's a good question.
This is a tumor biology question. My laboratory, one of the projects actually is studying the tumor stroma. The tumor cells are very invasive and aggressive and mobile. I don't think that the stroma it does somewhat contribute to the tumor cells going, but the process of a tumor cell intravasating into a blood vessel and then going elsewhere and extravasating is very different than a drug getting through blood vessel walls and penetrating through a tumor. And so the biggest determinant of a drug leaking through blood vessel walls is how big the spaces are around the blood vessel walls, which aren't very big at all. So the drug getting into a tumor is more of a passive process, where a tumor cell leaving is more of an active process into blood vessels. So they're very unrelated processes. That being said, if you look at we're going to get really scientific here, right? But if you look at the mouse models where they've ablated the stroma, right? So they took out all the fibroblasts and all the protein that make the stroma. Those tumors are actually much more invasive. So It's a bit of a conundrum or a controversy right now as to whether or not the stroma actually contains the tumor and keeps it where it is, or in some aspects it may help the tumor cells from going to go elsewhere. So we don't really know what to do with all this information in the stroma right now. But the thought is if we can deplete it, we can get more drugs in there. That's a good thing. But a potential bad thing is the tumor cells may be more mobile and invasive. So we need to make sure we're getting those drugs in there if we're going to take that stroma out. The tumor cell spread is an active process. Drugs going in there is a bit of a passive process. Other questions? Sorry, we'll go to the back first.
So the question is, how many clinical trials do we have running now? So at any given time, there's usually about 5 to 6 clinical trials at UCLA for pancreatic cancer specifically. There's a lot of other clinical trials that enroll patients with many cancers, of which a subgroup is going to be pancreatic cancer. So trials really, the way they work is you find patients come in, there's slots that are available, and then you enroll them, and it changes dramatically because they're only allowed, let's say, in each trial for X number of patients. And these trials are almost always not just at UCLA, they're at multiple centers around the country and sometimes around the world. So we're allotted X number of slots, and when those slots are filled, that trial closes, and then a new trial comes to take its place. So at UCLA now, the number is ballpark about 5 for pancreatic cancer specifically, and then there's a number of others that are for other patients, but of which they have a group of which includes pancreatic cancer.
It's a really good question. So as we looked at the environmental risk factors for pancreas cancer are mainly smoking and alcohol abuse. I don't think people are smoking more and folks aren't drinking more, so those aren't the reasons. But obesity and high-fat diet, I think, are 2 of the major contributors as to why pancreas cancer is going up. If you think about the pancreas, it does 2 main things. It makes insulin to regulate blood sugar in the blood, and it makes digestive enzymes to help digest food. And so I think that if you eat more food, you need more digestive enzymes to digest that food. It works the cells harder that makes those enzymes and probably causes some inflammation around the pancreas, which contributes to cancer development. So visceral fat, like intra-abdominal fat that men have more than women, once it becomes inflamed is thought to be a pretty bad thing. So pancreas cancer probably going up because of obesity and high-fat diets, working those acinar cells of the pancreas harder to make the enzymes, creating inflammation around there, and the visceral fat around the pancreas, which is working coordinately with the mutations. Sure, in the back.
Can I ask a neuroendocrine question at this point?
Sure. You gotta come back in February maybe? Oh, right, yeah.
So chemotherapy doesn't usually treatment for neuroendocrine. The question's about neuroendocrine tumors and how are they treated. And most of the time chemotherapy is not usually used in neuroendocrine tumor. So it's a different disease. It's a really different cell type, and the drugs are totally different.
When was that lecture going to be on?
Oh, Anne will tell us. It's sometime in 2016 or 2017.
It's going to be a 2017.
Right, so that's a very good question. So screening, the question relates to if you have a family history or if you have suspicious family history for pancreatic cancer, what should you do? And this is a real source of great controversy because, first of all, as we talked about earlier, there aren't too many well-defined genetic syndromes for pancreatic cancer. And the other challenge is there's not great screening tests for pancreatic cancer. So it's not as simple as it is, let's say, and it's not simple for any cancer, but it's certainly not as simple as it is for breast cancer or colon cancer. So no screening tests have been definitively proven for pancreatic cancer. There's a lot of studies that are done all around the country to look, and including CAP studies that look at families that have risk factors and try to enroll them on one of these screening protocols. Most people would say that if you have a strong family history of pancreatic cancer, you should get some screening, which could include either an MRI or a CT scan, a pancreas protocol CT scan, or under certain circumstances, even an endoscopy with an endoscopic ultrasound. But the specifics of who to screen and when are a very murky area and really depend on first-degree relatives and all of those variables.
Yeah, sure. So it was first described or done by Dr. Alan Oldfather Whipple in the 1950s or 60s in Columbia Hospital in New York. Somewhat conceited, named it after himself, but nonetheless, the mortality associated with it has really decreased markedly. It was before CT scanners were really used, right? So people were kind of blind in terms of what they were operating on. There wasn't an ability to detect any of the postoperative complications because there was no CT scan. It used to be done in a stage fashion, where if a patient presented with jaundice and had their bile duct obstructed, there would be a first operation to decompress that, and then once that settled down, to go back in later to do the therapeutic resection. Now it's all done in one stage and area. But I think the thing. So I'd say the things that have really improved the Whipple resection, which is now done as I said, one operation, are the better non-invasive imaging, CT scan, MRI, endoscopy, ERCP, which is able to endoscopically decompress bile ducts and make sure folks are in good shape to tolerate a major operation. And then the last thing, as I showed, is interventional radiology, because very rarely, I'd say only once every 2 to 3 years or so, do I need to reoperate on a patient who has had a Whipple, and that's doing like 100 of them a year. Because most of the complications, whether it be bleeding from a blood vessel or even an abscess development, can be managed with interventional radiology. So long story short, the operation used to be a staged procedure. It's now a one-step procedure. But the real mortality reduction and why we're so good at it today is not only because of the surgical technique, but also because of the ancillary services that work with the operation in and of itself. Was it a TED Talk? I think he was on 60 Minutes or 2020 or something like that.
That too, but I saw it on a TED Talk.
Oh, you did?
And he was able to isolate a marker.
No, it's true. So the question is about screening, earlier diagnosis, and a story that came out of Johns Hopkins maybe about 4 years ago. I know the principal investigator is Anirban Mitra. The principal investigator's lab where that all occurred, and we're good friends, and we talk frequently. It was an overzealous adolescent that publicized it a little bit too much, and so it never went anywhere because it wasn't particularly real. Gives you tremendous confidence in the U.S. media, I think, is the problem. There are other ones now that have some really promising preliminary data. They're looking at a combination of serum markers. There's another like glycosylated sugar that they're looking at. Exosomes, which are little vesicles that the tumor cells spit off that have like characteristic signatures. But I just came back from American Association for Cancer Research conference on pancreas cancer, and there is some promising earlier diagnosis work that's being done, and it's being done in collaboration with institutions internationally. So they're working hard on it. I wouldn't hold my breath, and I don't think it's some of these early hits still need to be thoroughly validated, but there is progress and improvement there.
And they have high schoolers in Facebook
They have high schools on Facebook. They have Facebook. Yeah, right.
So the question related to whether or not after you do Whipple, whether they're cancer-free, and we define cancer-free and use terms like remission based on what we see on the CAT scans or imaging or MRIs and blood tests. So if we see no evidence of cancer either by a CAT scan, MRI, or blood test, then we declare that patient cancer-free. And then there is sometimes a role for chemo still to try to maintain that remission. But technically, if it's gone, it's in remission and it's gone. The challenge is, in many patients, that cancer can come back. And so even though they're in remission, we can't use the C word, the cure word, until we get to a requisite period, which is somewhat arbitrarily defined as 5 years. So if you have a patient who's in remission for 5 years after a cancer has been removed, there's no cancer, by blood tests, by CAT scans, that we then call that patient cured of pancreatic cancer. And that's the terminology we use.
Is there a rate of return on pancreatic cancer, or generally after the Whipple, most people get into remission?
No, well, that's the challenge. Unfortunately, most people do relapse at some point after a Whipple. So that's where the challenges remain. Is after a Whipple, the surgeon's done their job, in essence, and the cancer still has a high tendency to recur. So that's fundamentally one of the problems. It's in the back. Yeah.
Dr. Donovan, can you talk about surgeries you're doing laparoscopically now?
Yeah, sorry. What surgeries we're doing laparoscopically? We're certainly doing distal pancreatectomies and splenectomies laparoscopically. We also have started to, 1 year ago, hired a trained robotic pancreas surgeon, and tomorrow we're having a second trained robotic pancreas surgeon join our group. So we're doing robotic pancreas surgeries, both Whipples and distal pancreatectomies and splenectomies, and we're doing laparoscopic distal pancreatectomies and splenectomies. I'm feeling old. I trained before the era of robotic surgery, so I do them all open, which I think is still probably the best approach to operate on cancers and to ensure you get negative margins. But we do have many different techniques and approaches available, which is all part of this multidisciplinary integrated practice unit where we have a dedicated center on pancreas cancer. So the questions about the microbiome and how that changes after a Whipple resection?
I guess, yeah.
Yeah. So the microbiome is a very interesting topic. So the microbiome, for those who don't know it, are just the bacteria who have become symbiotic with us and live in our GI tract. And it's thought that the microbiome in that GI tract may be the cause of a lot of our problems, including various GI cancers. There, to my knowledge, hasn't been a tremendous amount of work done on the microbiome and pancreas cancer. The pancreas is drained by the portal venous circulation, so the same veins that are draining your intestine, your colon, your small intestine go right by the pancreas. So it is certainly possible that there are some microbiome-related effects on the pancreas. I don't know about the change in the microbiome after a Whipple resection. Patients after Whipple resection get kind of crampy abdominal pain for a few months after surgery, but in the end, there are really few long-term sequelae, and they're able to eat and do whatever they want to do without any restrictions. So the question is about the tumor marker, and at the outset, when the first measurement, is it reflective of the burden of disease, and is the decrease or change determine surgery for folks? I'll explain that second part. The first part is someone with a marker of 15,000 at a disadvantage to someone who starts at 500? I think that the thought has changed about that in the last 5 years or so, and it's thought that really high marker levels are indicative of probably disease spread elsewhere in the liver or the lung or whatnot. And so I am very, very, very reluctant to operate on anyone whose marker is in the thousands. What we've shown is that if you're going to get, if you're being treated, to short circuit that 6 months, you got to get to normal. You got to get to normal. So regardless of where you start, you got to get to normal. But if you've had the 6 months of treatment and your marker has come down, it doesn't necessarily have to be normal, but somewhere in the range hundreds, I'd say up to 2, 3, 4, 500 at the very most. I think that we have tended to operate on those patients, and those are the folks that are in that greater than 6 months group right here whose marker didn't normalize. So the bigger assessment is that we want to make sure that we can get the tumor out and have those margins be negative. If you've had the 6 months of chemotherapy, we've had 6 months to watch you while you've been treated to make sure that disease didn't develop in the liver or the lung or elsewhere outside of the pancreas. And so, yes, the marker needs to drop. If you get it to normal in less than 6 months, we'll usually do surgery at that point. But as long as it's dropping into the low hundreds range, even if you start at an extremely high level, then we have tended to do surgery, yes. Yeah, so the question is about IPMNs, intraductal papillary mucinous neoplasms, which are precancerous cysts of the pancreas. And there's been kind of a moving target on how to best treat these lesions. There's international consensus guidelines that get more complex and change every time the group gets together. So, and there are two main types of these cysts. One is the main duct, the other is the branch duct type. The branch duct type have been known to be less associated with invasive cancers and those that have been resected. And the question is do we adhere to the guidelines, and are we okay with not operating on patients with side branch IPMNs that don't harbor any of those high-risk sequelae? And the answer to that question is yes, but it depends. So it depends on the patient's level of anxiety, it depends on the age, it depends on the functional status of the patient. But am I not operating on and observing patients with cysts that are greater than 3 centimeters and have no mural nodules in them? Yes, many, many, many of them, as long as they've gotten really good high-resolution imaging, including an endoscopic ultrasound, which I am very insistent upon, that doesn't show any of those high-risk sequelae. We looked at our series of side branch IPMNs, again, more papers and analysis, and the Sendai criteria was able to capture almost, if not all, of the cancers that we took out. So I think they are good guidelines, but the ones that I don't like are the ones that say, if it's 3 centimeters and there's no mural nodule on MRI, then you don't need an endoscopic ultrasound. I'm very uncomfortable recommending non-surgical therapy. I am a surgeon, completely understand that, in patients who haven't had an endoscopic ultrasound. We have the tool at our disposal. It's an outpatient procedure. It's very short. It's more high resolution than the MRI or CT scan. I think it's an important piece of data that I always recommend. Very rare, very rare. We often have the other issue. So the question is of the 100 that I do every year, or 150 we do every year, how many are patients who were told that they could not have surgery elsewhere? I'd say it's not zero. There are always some, but it's rare. I really think that that surgery is most beneficial in this disease if you can make sure those margins are negative. And we will comprehensively analyze that. We will assess it. We will assess it in more invasive ways than other people, like we talked about endoscopic ultrasound. If there's question of tissue around an artery, say, we're not going to dismiss that and not do surgery, but we biopsy it. We have an endoscopic biopsy to make sure that it is confirmed tissue. But I would say that we tend to be a little bit more selective, but I think appropriately selective in what should be done.